Welcome everybody to this webinar or this debate. You could call it kind of an internal punch-up between my colleague David Baker and myself. I'm Klaus Schmierer. I'm a clinical academic at Queen Mary University of London and Barts Health NHS Trust. And David Baker is a professor of Neuroimmunology at Queen Mary University of London. We're going to debate today the motion, should ocrelizumab and cladribine be treated in the same way as alemtuzumab in terms of risk of COVID-19. I'd also like to introduce our host today, which is Sarah Gillett, who runs the Neurology Academy and specifically the Multiple Sclerosis Academy. And thank you for organizing and arranging this debate.
Thank you.
We will now have a first vote on the motion. Then David and I will both give our views on the topic, and then there will be time for discussion. There's some questions that have already been submitted beforehand, and there will also be time for some live questions. And then there will be a brief sum up after that, and you'll be able to vote again. And it is going to be the swing vote that wins the day. Okay, so you can vote now.
So closing the poll, we have 67% no and a 33% yes.
Okay, very good. So thank you. Right, so should ocrelizumab and cladribine be treated in the same way as alemtuzumab in terms of COVID-19? Here are my disclosures. This is the motion that I'm voting for, which is that they should be treated the same way as alemtuzumab in terms of risk of COVID-19. So what the topic does not say, I think is also important to remember, is that it should always be treated the same way as alemtuzumab in terms of risk of COVID-19. And I'll come back to that at the end of my presentation. So as we all know, it started probably at a fish market in Wuhan, although it's probably not the fish that is conveying or transmitting the condition, but is rather a bat. And we can see that from similarities with the first SARS outbreak, which started in 2002 and was contained. And you can see that the total number of infected cases was just over 8,000, the fatalities 774. The bats were found about 1,000 kilometers away, and they have this funny nose, and that's why they're called horseshoe bats. And these little feral transmitters are probably involved before they manage to infect humans. Now, this is SARS coronavirus 2, which started in Wuhan in last year, December 2019. As of today, there's over 723,000 cases and over 34,000 fatalities. The death rate is estimated between 1% and 5%. And just for comparison, influenza is less than 0.1%. This is the infection rate per infected person. And you can see this is still not quite clear. So there's a low and a high estimate for that. But I think what is obviously relevant or highly relevant for the spread of the disease is that in SARS, you find spread or transmission only in symptomatic patients, whilst the problem with COVID-19 is that it's also spread in asymptomatic cases. This is the increment of cases up to the 27th of March. You can see that in Europe we're kind of high up there, and the US is now catching up. What is reassuring in a way is that there's loads of clinical trials also already either planned or in setup or underway. In fact, 199, according to a recent survey by somebody I didn't know, but is on Twitter, and so the increment of trials is quite similar at the moment as the number of cases we see. Mortality here in Spain, I think some people are joining from Spain. They have this sort of first-hand experience, and clearly there's an age preference of the condition to kill people of at higher age. This is a document which I can recommend here about which is steadily updated, and there's I think the reference, I don't know, have the reference down there, that doesn't matter, but you'll type it into Google, and this is how we think the uninfected or mildly affected people here on the left look like in terms of their lungs. This is the moderate and the severe cases. The severe cases signified by a cytokine storm type of appearance in the interstitial between the epithelial lining and the blood vessels. And this is kind of, these are the serious cases here. Overall, about 80% are mild. And as I said, pre-symptomatic transmission is about 50%, and moderate cases are 14%, severe 6%, which leads to the shortage of ICU and ventilation beds that we have now. So should ocrelizumab and cladribine against this background be treated the same way as alemtuzumab? So the principal issue here is, I think, should ocrelizumab be considered at the perceived higher risk of alemtuzumab and cladribine, or should alemtuzumab be considered at the perceived lower risk of ocrelizumab and cladribine? So you'll hear quite a lot of immunology from David, I'm sure, but I took a slightly different perspective on the topic, and that is very much the one of the practicing clinician. And we just run a survey, again, supported by the Academy, gratefully. And only last night I got responses in how the epidemic or pandemic has impacted on the way people practice medicine, or MSology, as it were. You can see what happened. There's lots of staff redeployed. Clinics have been cancelled in 71%. Treatments are delayed. There's communication issues, etc. So lots of problems that have emerged. Have you implemented any of this? So obviously this is the big time for telemedicine, over 75%. There's reduced blood and urine monitoring, really concerning, but overall it's a big time, as reflected in this meeting as well, for online information and clinics. Another element just recently was added by the Association of British Neurologists, the specialist subgroup, who changed the monitoring guidelines for all the disease-modifying treatments, or most of the disease-modifying treatments, and particularly lengthened the gaps for alemtuzumab from monthly to 3 monthly, and also for cladribine, so that the service can cope better. So I think one argument in favor of the motion is that we should keep it simple. People are just, they're frightened. They have a lot on their hands. They have loads of different tasks. Some of them have to retrain to become suddenly ITU physicians. So we need to keep it simple. My next argument is introduced by this, and I'm sure many of you will recognize this is a replica of the Old Bailey. And I think this one's in Canada, which has windows, which the Old Bailey in London doesn't have. And this is obviously a medical legal issue. And so when we're looking at who is making these decisions, and COVID hopefully will be over at some point, will we expose ourselves to risk if we do not follow what the reasonable body of responsible experts has decided? And it's just a reminder of the very few cases of lethal capillary leak syndrome that happened after beta interferon administration, when people forgot to look for a monoclonal gammopathy in these patients. And I remember at least one colleague who lost his license as a result of that. A very rare event, but with serious consequences, obviously for the patient, but also for the colleague. And David, you know full well this slide because you're a co-author. Now we say here 97% had no lymphopenia after a course of cladribine, but that's full, nice and well, but clearly there's also a number of patients who do develop grade 3 and 4 lymphopenia as a result of cladribine, and with reduced blood monitoring, you may well miss these. Now, you can obviously then come up with this type of list that nobody can read by a colleague of ours who's just published this. Or you can refer to the guidelines by the ABN specialist group. And so what they recommend is obviously social distancing for all people with neurological conditions, self-isolation with in the high risk category, and with neurological conditions. I mean, people with neurological condition are with low or moderate risk might be considered high risk if they have additional risk associated with comorbidities. Okay, so heart, lung, kidney disease, etc. Here are the recommendations by the ABN for the disease-modifying treatments. This is obviously truncated to fit in the window of a debate. So interferons or the CRAP drugs plus teriflunomide and DMF are generally safe to start or continue. Natalizumab, although there's been a single case of encephalitis, is generally considered safe. And I think it's also relevant that the NHS England in the UK has agreed to relax the eligibility criteria. Fingolimod, moderately increased risk. If on drug already, the risk of rebound may well outweigh the risk of infection, so that's a judgment call. Ocrelizumab, moderately increased, don't start or delay now, or delay further courses. And alemtuzumab, cladribine, and HSCT, all in the significantly increased risk bracket, or certainly of the first 3 to 6 months after administration. It's safe to increase the gap between the first and second treatment cycles. That's certainly true for alemtuzumab, probably also for cladribine. And if there's a third round considered, you can either use another DMT or delay until the pandemic is under control. So going back to the reasonable, so this is a reasonable body of responsible experts. So I think there's medical legal exposure, which is a risk, and therefore I would keep it as it is. There's another element, I've already alluded to that. Natalizumab has been relaxed, so there's that means that patients with high disease activity, as per their license, are included. They're not mandated to have 2 relapses over the last year, and MRI evidence at the same time. So this is my third argument. There's no need to take the extra risk during this crisis, since natalizumab eligibility criteria have been relaxed. And then finally, returning to my little footnote, as it were, that the debate does not say that it has always treated the same way. I think we should remember that lymphocytes recover even after alemtuzumab. T lymphocytes might take 3 years. It's slightly different with B cells, but hey, David, there are certainly some cases where that's much earlier the case. So I think it should much more dependent on the lymphocyte count then depend on the compound used. So that's my last argument, that the key is not the drug, but the lymphocyte recovery kinetics in the individual patient. And that's why I think you should all vote in favor of the motion. Thank you. And now it's straight on to my colleague, David Baker.
All right, thank you, ladies and gentlemen. Good morning. So the debate question I got was, should ocrelizumab and cladribine be treated in the same way as alemtuzumab in terms of LNS risk? And I guess my answer was no. But I have to obviously say I'm not a neurologist and I'm not clinically qualified. I come at the angle really from the science. So obviously, just to get a bit of science for Klaus, is that the bat didn't really give it to the furry cat. It was a scaly anteater called a pangolin, which we it's obviously it's important to think about the science. So I did make the slides myself, so that's the thing I want to say. So I guess the question, where did I start? And it really is from what Klaus was talking about, and that is really what the learned people would say, and going from the Association of British Neurology guidelines. So the question I've really asked is the opinions, are they kind of evidence-based or are they opinion? Because if we look at really what the ABN guidelines are saying, is that alemtuzumab is the same as cladribine. And I guess the question is where is the evidence? And we look and we say, it says, well, COVID-19 is not neurotropic, but indeed you do a little bit of searching and there is actually suggestions that maybe one of the issues could be neurotropism of the virus. So the question is, what is the evidence? And I think if you look at the evidence, it tells us that actually alemtuzumab is not cladribine, and it's not obviously ocrelizumab either. So this is obviously the picture that has been suggested by Klaus as the approach that should be taken as recommended by the ABN, which is obviously to either not start things or delay things. So the question is really what is the logic? Now, Klaus has got his ABN hat on, and as a good German, he knows that when he sees a red light in a road, what does he do? He kind of waits there and waits for the car to go by. And if it's a busy road, of course you would do that, because that's the safe thing to do. But obviously you can look down the road and say, well, there is no cars for a kilometre. So maybe we can think of a pragmatic approach. And off we go. And we can ask the question, is it really Vorsprung durch technique, when the technique is simply just reading? So we have to ask the question, what is the biology? So the question is, what is the opinion? Is it an opinion or is it really evidence-based? And from the British neurologists, their opinion is that alemtuzumab equals cladribine. But if we go to our friends in the southern half of the hemisphere, they will actually say, well, actually, alemtuzumab isn't the same as cladribine. So they say therapy isn't probably strongly immunosuppressive, it's mildly immunosuppressive, and there is no apparent increased risk of infection during early treatment, unlike what you see with alemtuzumab. So they're not the same. So what they suggest is taking a pragmatic approach. Now the question is where do you want to get your information from? Do you want to get it from a journal, or do you take it from Twitter? And a good example is the French health minister, Olivier Véran, which basically said that taking anti-inflammatories was bad for COVID. And of course, you can ask the question, where's the evidence? Well, is it because you just say, well, we know that COVID's caused by a virus, inflammation gets rid of infection, therefore don't block inflammation. But if you go to the EMA, of course, they say, well, there's no scientific evidence to link ibuprofen to disease worsening. So what's the real truth? And of course, then the British Royal College of Physicians weigh in and say, well, actually, the stuff on Twitter was based on anecdotal reports. So really what we want to do is think about the evidence. But they do make the point that there is a concern of anti-inflammatories affecting the inflammation. So the question we have to ask is, what do we know about the immune response to COVID? And what it's been shown in some of the cases is that there is a lymphopenia associated with severe COVID disease. Now the question, of course, is that because the lymphocytes there aren't there to protect us from infection, or is it because they're going into the lung to create the damage? And it appears that the infection starts off by the virus infecting by the angiotensin converting enzyme, which is expressed particularly in the lung epithelium. And what happens is the virus infects the cells. It triggers an escape mechanism by tries to block interferon while it replicates. The immune system then appears and starts to destroy the virus. And it appears that the really severe cases are largely a consequence of the immune response getting rid of the virus. So the question is what gets rid of the virus? Now, we don't know a lot about COVID-2, but we do know a lot more about SARS. And if you look at the histology of early infections, it was seen that the early lesions contain neutrophils, macrophages, and CD8 cells, contains few natural killer cells and few or no CD20B cells. It suggests that the CD8 cells are required for viral clearance, and obviously on secondary infection, it suggests that CD8s are important, and particularly also the neutralizing antibody response. So it tells us a bit about what is important in terms of protecting us from the virus. Now we can actually turn to experimental evidence, and where we have actually monkeys infected with virus, we can see a few things. So you give monkeys the coronavirus, and what you can see is that actually within 3 to 5 days, that the viral load disappears, and then you can re-challenge, and actually, besides symptoms for a short time, the virus really doesn't establish. So there is an immunity, and it tells us that the immunity, it kicks in, and it kicks in before 5 days. So let's look at what happens to the antibody response. So what you can see in these two individual monkeys is that one takes 21 to 28 days to make an antiviral response, and the other one takes 14. So essentially, the virus is being cleared before there is an established anti-IgG response, telling us that the cells responsible really for getting rid of the virus are probably not the antibody response in the first place, but maybe some cellular events. And if we then go to a patient who went to Australia, you could see that there was an asymptomatic period. It's roughly about 5 days, maybe up to about 22 days. And then what you can notice in blue, that the viremia on the swabs in the throat go down around day 7 and disappear. And then by day 10, the patient recovers. Now, if we then look at the antibody response, we can really again see that the antibody response doesn't really start to kick in until day 9 or 10, which is after really the virus has largely been cured, suggesting again that it may not be the antiviral response that is important in actually the first protection against the virus. It clearly will be important in stopping reinfection. And if we look at the antibody producing cells, they don't appear till day 8. If we look at the CD8 cells, we can see that they're present in numbers above health by day 7. They're obviously working. And if you look on the right, what you will notice is a substantial drop of monocytes from the blood. So the question is it because those monocytes are actually trafficking into the lung? And it actually is interesting that there was a case where somebody was having a lung resection due to actually a lung cancer, and it turned out that these people had pre-symptomatic COVID infection. And when you look at the lung of these individuals, what one can see is that they are full of macrophages. Maybe there's actually a couple of eosinophils there, suggesting that actually the early response to the virus is particularly the innate immune system, notably the macrophages. If we look at people who die with COVID, we can obviously see more of a lymphocytic infiltrate, because it's clear at that point that the CD8 T cell cytotoxic response is really going in, getting rid of the virus, and in doing so, doing damage. So it suggests to us that the first element is that macrophages and the T cells are important in getting rid of the viral infection, and then maybe, obviously, to prevent reinfection, antibodies are important. So where are we in terms of the ABN advice? Well, it suggests that alemtuzumab equals cladribine, which is slightly different from ocrelizumab. But I would suggest actually the biology actually says actually alemtuzumab, cladribine, and ocrelizumab are more or less the same in terms of their capacity to inhibit relapse. And that, in my opinion, perhaps is based on their capacity to inhibit B cells. Whereas the ABN idea is probably, well, both alemtuzumab and cladribine are T and B cell depleters. Well, that's true to some extent, but we have to look at the fine detail, because actually, if we look, really, cladribine is really a B cell depleter with a bit of T cell activity, and so that's much more similar to ocrelizumab. And maybe if we think about social distancing, actually we could think, well, maybe cladribine has some advantages over some of the other agents, as we'll see. Now, what is evident is that all agents that inhibit relapsing disease has a capacity to inhibit memory B cells from entering the central nervous system, and there's a hierarchy of agents. So the ones that do this well work the best. And if we look at some of Klaus's work using subcutaneous cladribine, you can see there's an 80% depletion of cladribine in blue 1 year after treatment, which is the same as alemtuzumab in red. Now, there's nothing special about this route. It can be seen exactly with oral cladribine. But the importance here is that you can achieve this effect without inducing substantial lymphopenia. So Klaus did mention that cladribine can induce lymphopenia, but in reality, the severe lymphopenia grade 3 or 4 only occurs in less than 3%, whereas alemtuzumab induces severe lymphopenia in over 80% of people. So you don't necessarily need lymphopenia to induce treatment. What happens with ocrelizumab? Well, we'll see here, essentially instantaneously after injection, you get B cell depletion, and B cells are kept essentially in their nadir state while you're on treatment, whereas essentially there is very, very little effect on the T and B cells. So the T cells drop by about 2%, and the CD8s drop by about 8%. And the B cells will maintain themselves in a low level until you stop treatment, but then it still takes a very long time for these B cells to repopulate. So it takes a median of about 15 to 18 months to actually replete your B cells. And of course, the memory B cells underneath that will take much longer to repopulate, suggesting maybe that there is some advantage of delaying if need be. This is just some data to show you that the memory B cells are depleted. But the important point is while you maintain treatment, that you keep a low level of immature B cells, and these are your response to new infections. So although we do know that you can make a vaccine response to agents with ocrelizumab, that response is blunted, and that's obviously one of the issues. Now, if we look at cladribine, we can see this is some data from the Clarity trial, I believe, that essentially people stayed within the normal range in terms of the T cell depletion. So really, in contrast to alemtuzumab, we're not really seeing marked T cell depletion. And it's of interest, of course, that if you actually then compare dimethyl fumarate, which is actually considered to be one of the safer drugs, about 20% of people actually can become CD8 lymphopenic. Now, it's very clear if we look at the difference between alemtuzumab and cladribine, that if you're treated with alemtuzumab, you stay lymphopenic for a number of years with a CD4, and probably about 9 months or more for alemtuzumab. And I think the important thing is when you look very early on, is that we can see lymphocyte depletion at 1 day after alemtuzumab, and that's there within 1 month. But perhaps more interestingly is if you look at the monocyte levels, there's initially a rapid drop, and in the first month or so, that there is a drop in monocytes, suggesting that maybe you're at additional risk during this early phase. And it is certainly the case that if you are lymphopenic, you are at increased risk of infection. And this is work done by a Danish registry. And you can see here, if you're at the very low level of lymphopenia, you probably have about twice as risk of infection. So where is the evidence? So the evidence is there for all of us to read. And it's clear that if you have alemtuzumab, you are at a much higher or a slightly higher risk of infection compared to cladribine or ocrelizumab. And the efficacy, I will argue, is relatively similar because the working mechanism is the same, is that you cause long-term depletion of memory B cells. The advantage of the alemtuzumab and the cladribine is that you're not maintaining therapy. And so once the drugs have gone, which for alemtuzumab is within a month, or for cladribine within 1 day of treatment, that whatever cells remain, they can then start to respond to any infection that comes along. So I think the memory B cell depletion gives us the effect on the infection risk, whereas probably the T cell extra depletion contributes to the infection risk. Now, in that case, I think it's very clear that alemtuzumab has more depleting capacities than either cladribine or ocrelizumab. And of course, there is potential advantage in thinking about how you try and avoid infection is by obviously keeping outside of hospitals. So obviously you want to ensure that your treatments are effective. And obviously you obviously want to ensure that you don't necessarily have to go to hospital to get your drug, or importantly, have extensive monitoring requirements that obviously will put you at an increased risk. So I think it's very, very clear from the science that alemtuzumab is not cladribine and is not ocrelizumab. And therefore, I think there is a distinction for believing that they should be different. And so the answer should be no. Okay, that's me done.
The pangolin, by the way, is hotly debated still, David.
Is it?
Yeah, there's gibbets, there's snakes, turtles. They're all potential intermediaries.
But there's the evidence. That's the question, Klaus. Okay.
I think the question, as it's being posed and asked, is a great sort of example how you can look at this from the immunological and scientific perspective. But if you're looking at sort of treating the topic, then obviously you also mean the handling in clinical practice. So how you do that, and I think this is the element that I've addressed. But maybe others want to chip in and want to say something. Otherwise, we could perhaps revert to the questions that Sarah sent in. Do you have them?
I've got them.
You got them?
We've got 3 live questions that have just come through on the Q&A, if you wanted to look at those first.
Oh, yeah. Let me have a look.
David, could you just stop sharing your screen?
Here we are. Yes.
Oh, yes. I haven't done that. Oh my God.
That's all right.
Okay, Lorna. Yes, the Lorna question. If you are COVID positive, when's the moment to restart high efficacy therapy? I think, after full recovery, and David gave some indication when that's likely to be, when you've cleared the virus. I think lymphopenia is also here a good indicator once that's recovered and you're symptom free. I think this would be the point at which you could be resuming treatment. The next.
Can I just chip in there?
Yes, do you want to add something?
I guess one thing, if we look at the biology again, if we think about how alemtuzumab works, it seems to target CD52. And what I would say is that it tends to be weakly expressed on plasma cells. Deoxycytosine kinase, which is how cladribine works, is weakly expressed on plasma cells. And obviously plasma cells don't express CD20. And it suggests to some extent, although obviously not proven, once you make the antibody response, then it's probable that some of these highly effective agents actually don't particularly target the plasma cell response. And therefore, what I think we're seeing with the COVID is about 100% of people have an immune response to an antibody response to COVID within 1 month, suggesting at that point you've probably got an established long-term immune response. And certainly we know with alemtuzumab that you don't seem to lose your childhood vaccine responses, suggesting again that once you've made an antibody response, that may maintain itself. And obviously that's potentially a good thing if you're thinking about whether you retreat, because the highly active drugs probably aren't initially targeting that element of immune protection. Obviously there's a concern in the long term with ocrelizumab whether you become hypogammaglobulinemic, but that hopefully is a long way away, and hopefully the COVID thing will be kind of semi dealt with by that time point. So I think the biology is quite handy there.
Yes. So highlighting that immunological memory is not dependent only on memory cells, but also plasma cell, long-lived plasma cells. So there's a further question. Are you suggesting that cladribine may be an option as treatment during this time? So that's what you're suggesting, is that right?
But the advantage is I'm not a clinician, so I'm not allowed to tell you.
Yes.
So I mean, that's why.
One could probably make the argument, say, well, you're asked to self-isolate, essentially, not self-isolate, but to practice social distancing at least, and you could self-isolate for 3 months, and could expect that the nadir of B and T cell depletion is kind of reached at that point, and you're kind of at the point of recovery. But I mean, dare I say, I mean, and only for the sake of argument, perhaps, it's a bit of a high-risk strategy, and against the backdrop of a very sensible decision, I think, that NHS England took here, that they relaxed the guidelines for natalizumab, which I think in this situation is probably the safer option.
Maybe.
Okay. Yeah, sure. I mean, nobody really knows, but I think we're discussing this to further that. So if you're a new patient, have very active relapsing, would you consider ocrelizumab for initial treatment right now? I mean, my answer would be no at this stage. I would probably start them on natalizumab and then consider switching them after at least 6 months. We obviously have a little bit of a challenge with service provision there, and we'll probably switch to extended interval dosing earlier than we used to, but I think this would be my strategy here. If there's a vaccine for COVID-19, will patients respond equally in any of the treatments? David?
I would argue probably not, actually. I think we know. I think there will be a vaccine. The question is when it arrives. I mean, there's no question there will be a vaccine. I think in terms of the data, what do we have? So there's data, obviously, with alemtuzumab, and you can make a vaccine response. And an example I would say, of course, is that if you have alemtuzumab, within the first month of alemtuzumab, 66% of people, or 60 to 60, make an anti-alemtuzumab response. So even when you've got essentially no T cells and no B cells, you can make an antibody response. And if you can make an antibody response, therefore you can be protected. So there's a potential there. In terms of ocrelizumab, the paper hasn't been published, but actually the data was actually put online in February. And if you go to the clinicaltrials.gov, you can see that people on ocrelizumab actually still can make an anti-vaccine response, but it is blunted. And the question is
at the academy last year, yes.
So even while you're actually completely B cell depleted, you can still make a response, and that's partly because only 2% of the lymphocytes are in your blood, and obviously there are still things in your spleen and your lymph nodes is where really the antibody responses are being made. And I guess the question, of course, is if we then took an extended dosing interval, which may happen, as suggested maybe by the ABN, is that some of these cells will start to recover. And it's the immature and the mature B cells that are going to give you the protection to new infections. And they're the ones that will respond to a vaccine. So that may be the case. We can only surmise what will happen with cladribine because I don't believe we have the data. I guess the sad thing is obviously the way that the cladribine clinical development profile was stopped, and so we don't really have that long-term data, which we do with the other drugs. But theoretically, obviously, you could say that within a few months that the immature B cells start to recover, and therefore you've got T cells at that time point, and there again, there's no logical reason why you shouldn't be able to make a vaccine response. And I guess time will tell, and what will be done.
Yeah, it's also quite encouraging these first plasma transfusion patients. You probably read about those 5 who all seem to have done
I guess
well, which is obviously a small anecdotal report so far. Regarding
can I answer that one? I mean, that's the Dustin Hoffman approach. I don't know if you remember Outbreak, where they had the little monkey and they kind of bled it, and it saved the world. But they have been taking blood from people who have had the virus, and they have transfused it, and it is actually having some effect even in people who are severely affected. So it clearly shows that the antibody response is still part of the protective immune response. I would just argue that it will be particularly important in stopping you getting reinfected, because this virus isn't going to go away from the population anytime soon.
After what you said about how the viral kinetics is, it is surprising in a way that it should work right at that sort of later stage, at this more established stage of the condition. So we'll see further reports. So regarding lessening hospital attendance requirements with some drugs, ocrelizumab, and risk of HAI, so that's autoimmunity, isn't this a significant factor? I'm not sure I get the full gist of that question. I think there's definitely, I mean, and this is what David showed in his slides, that I think we're looking at the extended period that ocrelizumab works, not only in the situation of COVID-19. We have, I mean, the model discussion about this is actually pregnancy, because patients, women who want to get pregnant, need to be reassured that the drug actually works beyond its dosing interval. Otherwise, they obviously become very nervous about what's happening. And I think it's not about plucking that out of thin air, but it's supported by certainly by the phase 2 data, by the Swedish rituximab data. So this is why I think it's a very good option to defer ocrelizumab if you're on it by 3 months. Hopefully, it's only 3, and then resume treatment.
Can I just interject, Klaus? Again, that speaks to potentially the biology, if correct, because obviously I've been suggesting that the memory B cell pool may be the thing that is important here, and it's very clear that once they are depleted, they actually stay depleted for a much longer period than the CD19 population. So you probably, if true, you get actually much longer level of protection than actually your repopulation B cells suggest.
Yeah, absolutely.
I guess.
The next is Iman. Hello, Iman. She's obviously calling in from Oman, a young colleague. Would you test patients before starting DMTs for COVID-19?
I wish.
Exactly. So we all wish to be tested regularly, in I'd say in even hotter situations. But the problem is at the moment the availability of testing. But I would definitely want to know, is there currently an acute infection going? Yes.
It would be helpful to know if you've had the virus. Remember,
of course,
50%. I think 50% of people are based on the Icelandic population seem to be asymptomatic. So, if you've had the virus, then that again, maybe it will impact on how you think about treating.
Yes.
Because again, you want your B cells to be around there to make the response.
Next question is anonymous. What happened if someone is already been administered with cladribine first week and it is positive for COVID-19? Does this person have to stop or delay the second week of administration? I think it's a very good question. We've been discussing this in the context without testing, just in the face of the crisis, what we're going to do with those who haven't had their second week of treatment. And generally the agreement was, in the end, that we will give that second week because we've started that treatment cycle and then move on. There's no scientific or so good reason to do that. This is kind of a practical approach. I think if I'd know that that there's a current infection, I'd find that out between the 1st and the 5th week of treatment. I would probably not give that second part of the treatment, and rather move to something safer in the current situation, and then retreat subsequently. But David raised his hand and opposes this view.
No, I don't. I'm just, again, going to make a point is, from what we know on the biology, that with cladribine, we know actually it's a slow killer. And if you notice the thing, most of obviously the drop goes in the first month. There's a slight drop in the T cells between the first and the second month, and then it starts to recover. So probably a lot of the benefit is actually from the first dose.
Yes, and that first dose has already a significant impact on the populations, because probably they are at their nadir between 2nd and 3rd month. So I think if you then just find out somebody's been COVID infected, I think I'd be a bit reluctant. Okay, next question is, if a patient's COVID-19 positive on natalizumab treatment, what would you do? Stop or delay infusion of natalizumab? I think it depends really on the severity of the disease. I think if it were a mild or moderate manifestation, and that is something that rather seems to be the overall arc of the disease course, I would probably continue. Having said that, I mean, natalizumab, if we give extended interval dosing every 6 weeks, then I mean, you could be unlucky that it's just before the next dose is due, and I think it's then a judgment call. From my reading of the data so far, I'm not convinced that there is a significant detrimental effect, but I may be wrong. And I mean, people have pointed out that there's been a higher rate of respiratory tract infections in the trial program altogether, and so I think one has to keep sort of an open mind on that question. Due to interferon antiviral mechanism, could we make a switch from cladribine to interferon in order to protect our patients in the meantime? I think it's a good question, and it's one that I think has a scientific basis. David?
I think we'll actually get that answer to some extent, because there's certainly trials with alpha interferon ongoing now. So I think from the COVID-B, the SARS, there was some evidence that beta interferon is antiviral. So I mean, that's what beta interferon does. I guess it's looking at the evidence to see how it works. And I think, you know, there are a lot of trials ongoing that will probably get the answer, or start to get answers to some of them in a couple of months, probably.
Yeah. I think the question is here when this situation will realistically emerge. I think at the moment, if you've had cladribine, you would probably just wait and see and sit tight. And then if there is no disease activity, I think this is the question that you need to address. Yeah.
I think the other important thing is you know, beta interferon is important in stopping viral replication. And in reality, at the moment, you know, we're told to stay at home, and we're not really being treated with antivirals. And so the real problem with severe respiratory problem is a bit later, in the kind of second week, where the immune response is then really destroying the virus that has replicated. So it kind of is a slightly different kettle of fish. You'd probably be wanting to treat kind of early. So I guess we'll see the experiments ongoing that how people with beta interferon do. I mean,
yes, or in fingolimod.
Yeah,
it's because that's also ongoing. Okay, so do you think that taking the first course of cladribine at this moment is safer than taking the second course because the prevalence of lymphopenia is different? I think there's probably not such strong evidence for that anymore, since the redosing is dependent on minimum lymphocyte count. So I don't think there's a very strong argument in favor of that. I think in terms of, if you, I mean, there's always about probabilities. In all likelihood, it'll be fine, but you may end up with somebody who does develop severe disease, and then you are in the territory of the capillary leak syndrome or other sort of rare conditions that you may have been able to prevent by not being quite as adventurous and go for a safer option. Professor Baker had a slide where it was written that in ocrelizumab, immature B cells depleted permanently. Maybe that was a wrong reading of your slide. David, do you want to correct?
No, I think what I'm saying is that it maintains the B cell pool at a low level. So while you're on treatment, then that will stay low, because obviously as soon as the new cells appear, that the ocrelizumab will get rid of them. I mean, I think what happens with ocrelizumab, it's given at such a high dose that actually it's still there depleting 5 or 6 months later. And so as the new cells reappear, they get kind of attacked, whereas they wouldn't with alemtuzumab or cladribine. And then maybe that's obviously where there will be one advantage really for ofatumumab, which is obviously going through the regulatory processes, because there it reverses very, very quickly. So I think obviously within probably this year you'll have alternatives. So but that'd be quite interesting, I think.
Yeah. There's a question from next one. How do you feel about natalizumab extended interval dosing to reduce the risk of COVID-19 without strong evidence of efficacy of extended interval dosing? Well, I think it's there is good evidence from the Neurology paper last year, Ryerson, and although it was obviously not targeted towards that, but I think it's very much matched to the experience by many who see patients in clinic. I think the ideal situation probably would be, and that applies to not only to natalizumab but to other monoclonals as well, is an adaptation of the dose to biomarkers or to other indices or such as weight, surface, or rather a response parameter really. If a patient had been treated by only one cycle of Ocrevus, would you delay the second cycle of Ocrevus 3 months, or would you delay the infusion only after the second cycle of ocrelizumab? Yeah, this is again kind of the situation of sort of half and half. I think it's a judgment call. I would probably be inclined to complete that first course and then leave people alone and ask them to self-isolate as good as possible. I think these are all the questions that I have here on the list. Should we move on to, maybe we need to vote straight away? We're running a little bit late, do we?
If we could do that, just because if it gets to 1 o'clock and other people have got other calls or meetings to go to, it would be good to relaunch.
Yes. Okay.
So I shall.
Okay, very briefly. Yeah. Okay, good. Yes. So my argument's in favor. No. Okay.
And the science says no. Just like Nancy.
You can both, if you want to cut
it simple, medical legal exposure, there's no need, and the key is not the drug, but the lymphocyte recovery kinetics.
While they're voting, if you want to put a few words across, you can.
Yes, well, I'd like to thank my my opponent to give such a good debate. And I think for everyone to be so engaged and ask questions, which is great. This is obviously not the final word on this topic, but I think it kicks off what I still think is an important discussion, because after all, we are now talking about 3 months, 4 months, but are we sure? Are we not talking about 13 months or maybe more? And I think therefore these questions may well come back again.
I would just like to probably add, the experiment is ongoing, so you can look at Twitter, for example, #MS COVID-19. And I would probably also recommend, if you've got patients that in the UK, that they go up to the MS register, because they're obviously trying to keep a watch on what's happening to people with MS. And, you know, the experience will really tell us what's safe and what's not.
Yeah.
Okay, we're just calculating the scores, so that from what we had previously voted. So I think Jamie's just checking the numbers for me. Do you wanted to do a couple of questions that came through that we'd had previously, Klaus, just while we calculate the scores?
Let me just go back.
You just want to make sure that we're making sure that the same people numbers voted in the first. And
okay, yes. Let me just. Okay. So I've got, in terms of protecting oneself from viral infections, do you view a specific immune cell type as more critical, or rather do you believe their combination as responders to infection is key? David, that's what you discussed earlier. Do you want to repeat that?
Yes, I think there are some cells that are, you know, particularly antiviral, but that the immune system is a system, so it uses macrophages, T cells, B cells, and having all of them gives you the best protection.
Yes, that's right. Question, do you have any experience with MS patients on DMTs who have contracted COVID-19? And do you have any updates on how they're doing? Are they responding differently than non-MS individuals? I must say, I'm not aware that any of my patients so far has contracted COVID-19. I'm pretty sure some have, but I have no way of knowing that at the moment, unless they become symptomatic, unless they are admitted to hospital. And fortunately, that's not been the case. Hopefully, once testing gets underway, I get a really much better idea of that. Sarah, are you done?
I think, Jamie, we're just waiting for...
it's a big calculation. Sorry, yes.
Yeah. In the interim, I'll just say that I got an email from Wallace Brownlee, who had a patient who had a partner who was infected from Italy and was definitely COVID positive. They showed COVID-like signs 6 days later, and made a recovery about 1 week later. They developed the disease 2 weeks after alemtuzumab. So obviously we can't say that they were definitely COVID positive, but obviously if that is the case, that it says they were certainly lymphopenic at that time. So
nice, you held that
could be hopeful.
This was an argument in my favor, wasn't it?
Yeah, they voted already. Too late.
Just typing the numbers up. Okay, let's have a look. Show the result. So we have 74 no and 26% of the yes.
Okay. All right. I'm a good loser in that one.
Well, thank you both very, very much for your time.
Thanks everybody for participating.
Thank you.
The question. Thank you. All the
And
best to you. Keep safe. Yeah. Bye-bye.
Bye.
Thank you. Bye-bye.